Okay, so for my topic to research and do my literature review over, I titled it Unit Staffing Within Hospitals. I put why below who and how just because why are staffing ratios in nursing departments put the way that they are, who determines these, and how do they make these decisions. So, how I arrived at this topic is just I previously worked on a medical surgical unit at a hospital, and there was just a lot of discrepancies, a lot of argument about whether nursing staff should be higher or lower. Obviously, most people thought that we should have more staff on the floor and less patients per staff for both nursing assistants and for RNs. I later moved to a postpartum floor on the mother baby unit, which is where I'm at now, and I just found it very interesting how it differs, and also how it's the same between night shift and day shift. They have the same amount of couplets, is what we call them. However, on my previous floor, the ratios changed between day shift and night shift. So I just am wondering, why are these grids set the way that they're at and who sets them? So my major findings from my first article, which is titled World Federation of Critical Care Nurses 2019 Position Statement, Provision of Critical Care Nursing Workforce, kind of a mouthful. The authors are in the bottom right-hand corner of the screen, as you can see. So from this first article, it was just research from a critical care unit. They gave recommendations for what they found to be successful in their units. They recommended very low ratios, preferably a 1-to-1, if at all possible, between nursing staff and their patients. This is based more on individual cases, they said, so that grid can change based on what individuals' cases look like. So if one patient required a higher level of care or more intense care, a 1-to-1 ratio would be preferred. However, if two other patients perhaps needed less care, a nurse could pick up two patients as opposed to the preferred one. They also highly encouraged having a staff leader, which I believe most nursing units do have, also known as a core nurse for the night. And they also encouraged having at least one senior nurse on the floor for younger nurses or other nurses just in general to be able to ask questions, someone who knows the ropes. Some strengths of this article that it gave very specific and direct recommendations for a critical care unit and what they found to be successful. However, weakness was that, again, it was only applicable to that one critical care unit, which can be differing from different floors and different nursing units. The authors for this article are located in the bottom right hand of the screen. So, for major findings in my second article, it's titled Evidence on Nursing Staffing Ratios and Patient Outcomes in a Low-Income Country, Implications for Future Research and Practice. So, this article was researching a medical surgical floor, which I found interesting because that's where I started off as. And they said that having lower ratios improved some patient outcomes, but not all of them. So these patient outcomes that they included were things like pressure sores, falls for patients, accidents in bed, such as wetting the bed or bowel movements. So it stated that skilled and experienced nursing was more effective. Having that skilled nursing on the floor was more effective than just, say, more bodies of nursing staff on the floor. And it also compared medical surgical units to critical care units and how this may differ for a medical surgical unit. One strength of this article is that it just used very specific examples and explanations of what would be considered improved patient care. So obviously, having less falls is going to be less or a greater patient care. A weakness was that by the end of the article, they pretty much just said that their research was inconclusive, that they weren't really sure if it would be considered worth it to have more nursing staff on the floor, or if it would be more worth it to have more experienced, a higher level of care nursing. So, kind of unfortunate. Again, the authors for this unit or for this research article are located on the bottom right hand of the screen. So my final article is titled Are Hospital Nurse Staffing Practices Associated with Post-Operative Cardiac Events and Death, a Systematic Review. So this article just showed direct relationships between having higher nursing levels and lower mortality rates. There was a inverse or direct relationship between those. Higher nursing levels led to lower mortality rates. This is what I consider to be one of the strengths of this article. It was just very clean cut, very clear, like this happened because of this. Relationships between higher education beyond registered nurse, so just associate's degrees, had a lower mortality rate. And then it said that also having more support and interaction between bosses or higher ups within the system contributed also to these lower mortality rates within the unit. In general, they said that this is a weakness of the article. There was just a lack of information for them to really make any strong determinants. It's just more of a general increase and decrease. So, and obviously there's a limited ability to be able to test this because you can't sacrifice patient care. So my healthcare partner that I interviewed on this topic was a unit leader in the hospital. So she said she pretty much had limited information for me. She said that nursing staff grids and ratios are always determined from higher ups within the system beyond just her level in the hospital. So she told me that she and other nursing leaders, whether that's the unit leader, whether that's the staff development nurse, whether that's cores, they're the biggest advocate for being able to change these nursing grids. But she said also beyond just advocacy of leaders and people who work within the floor, it's just based on research of other systems. A lot of hospitals, she said, will communicate amongst each other to decide, well, did this work for you? This is not working for us. And then also based on previous experience, obviously, within your own system. So there's a few gaps within my research. It's difficult to research healthcare outcomes in general. You never want to sacrifice quality of patient care just for research to decide for later patients. That's just a patient right that we all have to respect. And also, it's very difficult to determine one thing that could apply to all different units of nursing. Obviously, postpartum mother baby, so much different than medical surgical, so much different than critical care units. So it's just hard to pinpoint one topic, one all fix all that could work across the entire board of nursing. So that's one of those things that I wanted to, for further research, I think it would have been maybe a better idea to just focus on one unit and decide like what has medical surgical found to be successful or what has mother baby found to be successful. And I also think talking within different leaders within systems would be helpful too. Obviously, it's very hard to sit down with a leader of Methodist Hospital, but I think that could be also helpful, and just comparing between the two different units and finding different correlations between them. And my last slide here is my references for my 3 articles.